Hello, I'm Jason Kai from the Radiology Informatics Lab at Mayo Clinic Rochester. Today, I'm presenting our work entitled Fully Automated Deep Learning Model to Detect Clinically Significant Prostate Cancer on MRI. Prostate cancer is the second most common cancer in men. In this study, we developed a deep learning model to predict the presence of clinically significant prostate cancer on multiparametric MRI using patient-level labels. The study included 7,854 patients without a history of clinically significant prostate cancer, defined as Gleason score 7 or higher. Of these, 1,454 patients had clinically significant cancer on biopsy. 3,761 patients were considered negative through either biopsy or PIRETS 1 or 2. The internal dataset was split into 5,035 exams for training, 300 for validation, and 400 for testing. Additionally, the Prostate X dataset containing 204 exams was used as an external test set. For the internal test set, a patient-level PIRETS was obtained from the radiology report. For the external test set, radiologists assigned a patient-level PIRETS to each exam. We developed a model to predict clinically significant cancer from multiparametric MRI, which we refer to as the image-only model. The model's output did not include the location of the tumor. Therefore, voxels that contributed to a positive prediction were visualized using GradCam from the final convolutional layer activations. We also trained a neural network to predict clinically significant cancer from PSA and PSA density, which we refer to as the clinical model. The predictions of the clinical image models were combined using logistic regression, which we refer to as the image plus clinical model. Additionally, the predictions from the image plus clinical model and PIRETS were combined using logistic regression, which we refer to as the image plus clinical plus radiologist model. When the entire internal test set was evaluated, radiologists had an AUC of 0.89. The image model had an AUC of 0.89, p-value 0.88 in comparison to radiologists. The image plus clinical model had an AUC of 0.91, p-value 0.42. The image plus clinical plus radiologist model had an AUC of 0.94, p-value less than 0.001. When patients without pathology diagnosis were excluded, radiologists had an AUC of 0.78. The image model had an AUC of 0.85, p-value 0.01 in comparison to radiologists. The image plus clinical model had an AUC of 0.88, p-value 0.001. The image plus clinical plus radiologist model had an AUC of 0.87, p-value less than 0.001. When the external test set was evaluated, radiologists had an AUC of 0.84. The image model had an AUC of 0.86, p-value 0.68 in comparison to radiologists. The image plus radiologist model had an AUC of 0.89, p-value less than 0.001. The Prostate X dataset does not contain clinical data. GradCams overlap with the lesion in 35 of 38 true positive exams in the internal test set. Here is an example. It overlapped in 56 of 58 true positive exams in the Prostate X dataset. Here is another example. In summary, our model's performance was not statistically different from that of experienced radiologists. GradCam localized the lesion in the majority of positive predictions. Our approach is unique in that ground truth labels contain only the presence or absence of clinically significant cancer at the patient level without information about tumor location. We believe that our model can potentially assist radiologists in identifying lesions and facilitating biopsy, hence improving the diagnosis of prostate cancer.